Dr. Gordon, over to you whenever you're ready.
Good evening, consultants, and our trainers, and good evening to everyone. Welcome to this evening's presentation. Today, we would have the first section for our curriculum presentation. Dr. Chineme Ike is presenting on gross anatomy of the heart, the valves, and conduction systems. And the next one, she has the floor. Dr. Chineme, please, are you ready?
Yes, good evening, Chief.
Thank you. Please, you can share the slides and go ahead.
Hey, good evening, consultants and my seniors and all on the call. My name is Dr. A.K. Chineme, and we'll be looking at gross anatomy of the heart, the valve and conduction system. Dr. Gordon, I think is a very large topic, so maybe the next presentation I'll do the coronary arteries. So as a way of introduction, the anatomy of the human heart and its great vessel is essential to us understanding the basis of cardiology, and the knowledge of the anatomy of the heart dates back to the 19th century when only anatomists and pathologists had interest. And from the mid 20th century, cardiologists and surgeons developed interest due to the advent of cardiac catheterization and geography. So it's very important to understand the structure. So this is a diagrammatic presentation of what the heart structure looks like. We can go through it later. So the heart is a conical, hollow muscular organ that is located in the middle mediastinum. I hope I can be heard.
Yes, you can be heard.
Okay. So behind the sternum and the costal cartilages of the third and fourth and fifth rib, okay, and it lies obliquely. So the third of the heart is to the left of the midline. So the heart rests upon the diaphragm and is tilted towards and to the left, so that the apex is anterior to the rest of the heart. So the size and the weight of the heart varies depending on the age, the body length, the epicardial fat, and the general nutrition. But the average human heart weighs about 75 grams in females, and then 275 plus or minus 75 grams in females, and then 325 plus or minus 75 grams in males. So it weighs more in males than females. The heart has four chambers. It has two atria and two ventricles, and they are externally separated from each other by sulcis, and they consist of surfaces and borders, as we'll see. The atria lying above and behind the ventricle. So the sulcis, we have the right and left coronary sulci, the interatrial groove, and anterior and posterior interventricular sulcis. The surfaces, we have the diaphragmatic surface or the inferior surface, the anterior or the sternocostal surface, and then the left surfaces. And then for the borders, we have the right border, which is usually formed by the superior vena cava and the right atrium. And then we have the left border, which is formed by the left ventricle and the left auricle. And then the inferior border that is formed basically by the right ventricle. So this is a diagrammatic representation of the heart. As we can see the borders clearly, and then the sulcis that are running in between. So we can always look at this because of time. And then this is like the inferior view of the heart, where we can see the left ventricle, the left side of the atrium, the coronary circles, and then other vessels. So we'll start with the right atrium. So the right atrium is a quadrilateral chamber. It's situated behind and to the right side of the right ventricle. Externally, it is separated by the right coronary sulcus. A holoconical muscular projection, which we call the right auricle or the right atrial appendage, arises from the anterior superior part of the right atrium, and it extends upward and to the left of the ascending aorta. So along the right border of the right atrium, there's a shallow vertical groove, which we call the sulcus terminalis, which extends between the orifices of the superior vena cava and the inferior vena cava, and is produced by an internal muscular ridge called the crista terminalis. So the internal features of the right atrium, the wall measures about 2 millimeters in thickness, and then the interior part of the right atrium is divided into 3 parts. So it's divided into the smooth posterior part, which was made by the sinus venereum, if we remember, during development, where the right horn of the sinus venosus is being taken into the right atrium. So it forms the smooth part, while the rough part is the pectinate part that is formed by the primitive atrium. If we remember the tube, like the cardiac tube, when they are divided. So you basically have the truncus arteriosus of the conus cordis, the bulbus cordis, then beneath it, you now have the ventricle and then the atrium. So the bulbus cordis, the lower one third, that's the proximal one third of the bulbus cordis, is what forms the ventricle, and then the atrium along the tube is what forms both the right and the left atrium. So the one from the primitive atrium is the rough part. And then the septal wall, which develops from the septum primum and secundum during the division of the atria. Then the openings in the right atrium, it has basically 3 valves. So the superior vena cava that opens from above, that one has no valve. Then the inferior vena cava that has the eustachian valve that opens from beneath. And then the coronary sinus that opens into the right atrium via the Tepesian valve. So this is a diagrammatic representation. As we can see, the crista terminalis, or the terminal crista that divides or separates the rough part from the smooth part. Then we can see the pectinate muscles. We can also see beneath the Tepesian valve, the eustachian valve, and then the fossa ovalis. And also this area is very important, as we'll see later, because of the trigone where the AV node sits. And then we can see the superior vena cava opening from above, and then the right atrial appendage. So the features of, now we're looking at the interatrial septum, which forms part of the wall of the right atrium. So the fossa ovalis is an oval depression above and to the left of the opening of the inferior vena cava, while the limbus fossa ovalis is like the sickle-shaped margin that was formed by the secundum during development and surrounds the upper, anterior, and the posterior margins of the fossa ovalis. Then the patent foramen ovale, which is a slit-like valvular opening between the upper part of the fossa ovalis and the limbus. And then the torus aorticus, which is a bulge in the anterior superior part of the septum due to the bulging of the right posterior non-coronary sinus and the right coronary cusp of the aorta. Now we'll go to the right ventricle. So the right ventricle is a triangular or a crescent-shaped chamber. The right ventricle is normally the most anterior part when you're looking at the heart. So it lies directly beneath the sternum, and it is partially below, in front, and medial to the right atrium, but anterior and to the right of the left ventricle. So it forms about 2/3 of the sternocostal surface and 1/3 of the diaphragmatic surface of the heart. The internal features of the right ventricle is thick, 4 to 5 millimeters in thickness. So we can see it's thicker than what we had in the right atrium. And then the interior of the right ventricle consists of 3 main portions. So just like the right atrium, it has the trabeculated portion, which is usually close to the apical part, and it develops from the primitive ventricle. And then it has the smooth outflow part, or the infundibulum, which comes from the right part of the bulbus cordis, and then the right inflow tract, which develops from the primitive ventricle also. So the rough inflow tract consists of the tricuspid valve and the trabecular muscles of the anterior, which are arranged into ridges or bridges and pillars. That's the papillary muscle. The septomarginal trabeculae is a muscular ridge extending from the ventricular septum to the base of the anterior papillary muscle, and it contains the right branch of the AV bundle and is presumed to prevent the overdistension of the right ventricle, hence it's called a moderator band. And then the supraventricular crest, which is the muscular ridge situated between the tricuspid and the pulmonary orifice, separates the inflow and the outflow tracts into the right ventricle. Now, the smooth outflow tract forms the superior portion of the right ventricle and it gives rise to the pulmonary trunk. The apex of the conical-shaped infundibulum has pulmonary orifice guarded by 3 semilunar cusps. And then the blood entering the infundibulum is ejected superiorly and posteriorly to the pulmonary trunk. So now we'll look at the left atrium. Now the left atrium, the anterior wall of the left atrium is formed by the interatrial septum, while the posterior surface of the left atrium forms the anterior wall of the oblique sinus of the pericardium. So its appendage, the left auricle, projects anteriorly to overlap the infundibulum of the right ventricle. Now the wall of the left atrium is about 3 millimeters thick. Most of the wall is smooth and only a network of musculi pectinati is present within the left auricle. The 2 pulmonary veins open into the left atrium on each side of the posterior wall, that's making it 4. There are no true valves at the junction of the pulmonary veins and the left atrium, but the sleeves of the atrial muscle extended from the left atrial wall around the pulmonary veins for about 1 to 2 centimeters and may exert a partial sphincter-like influence, tending to lessen the reflux during atrial systole or mitral regurgitation. And then the atrial septum shows the fossa lunata, which corresponds to the fossa ovalis of the right atrium. And the left ventricle is roughly bullet-shaped, it's ellipsoid, with its blunt tip directed anteriorly and inferiorly to the left. And the left ventricle forms basically the apex, 1/3 of the sternocostal surface, most of the left surface, and 2/3 of the inferior surface of the heart. The left ventricular walls are about 8 to 15 millimeters thick. However, the tip of the left ventricular apex is often thin and measures about 2 millimeters or less. And the left ventricle consists of the ventricular septum, the free wall of the left ventricle, the inflow tract, the outflow tract, and then the apical portion of the left ventricle. The ventricular septum, the medial wall of the left ventricle, is the ventricular septum. So it is roughly triangular in shape with the base of the triangle at the level of the aortic cusp. It is entirely muscular, but a small portion located superiorly just below the right coronary and posterior coronary cusp is membranous. So the upper 1/3 of the septum is smooth endocardium, while the remaining 2/3 of the septum and the remaining LV walls are rigid by interlacing muscles and the trabeculae canal. Now the inflow tract, the anterior medial leaflets of the mitral valve extending from the top of the posterior medial septum to the anterolateral ventricular wall separates the LV cavity into an inflow tract and also an outflow tract. So the funnel-shaped inflow tract is developed from the left part of the primitive ventricle and consists of the mitral orifice and its mitral valve. So the outflow tract, the conical smooth-walled outflow tract, is situated above and in front of and slightly to the left of the mitral orifice and is basically developed from the left part of the bulbous cordis. And it's surrounded by the inferior surface of the anteromedial mitral leaflet and the ventricular septum, and also the left ventricular free wall. So it orients the blood flow from the left ventricular apex to the right and superior at an angle of 90 to the inflow tract, ejecting the blood into the ascending aorta through the aortic orifice during ventricular systole. And the summit of the aortic vestibule is occupied by the aortic annulus, guarded by the three semilunar cusps. So the pericardium, the parietal pericardium is attached to the sternum anteriorly and to the diaphragm posteriorly. And the pericardial space contains about 15 to 50 mL of serous fluid as a lubricant. Majority of the great vessels are within the pericardium. Two-thirds ascending aorta and main pulmonary artery. Then half of the superior vena cava is within the pericardium. And then the short segment of the inferior vena cava is within the pericardium. So this is important in cases where we have constrictive pericarditis. So the epicardium now is composed of fatty connective tissues. The myocardium is made up of interdigitating layers of myocardial cells with accompanying vasculature. And then the endocardium comprised of a thin layer of fibrocellular connective tissue within a single layer of the endothelial cell lining. Now for the ultrastructure of the myocardium. So the myocardium has contractile cells, and they're about 10 to 20 in diameter and 50 to 100 micrometers in length, surrounded by a cell membrane known as the sarcolemma. So the sarcoplasm has many mitochondria and centrally located elongated nucleus, and many up to 50 to 60 myofibrils, which are actually inserted in the region of the intercalated discs. Each of these myofibril is about 1 to 2 micrometers in diameter and lie parallel to one another, and they are composed of a series of sarcomeres, which are the basic contractile units of the myocardium. So the cell membranes of some adjacent cells form closed margins called the intercalated discs or the junction. The contractile myocardial cells are similar whether they are from the atrium or from the ventricle. And however, the contractile myocardial cells, which contain an intricate sarcotubular system of tubules, vesicles, and cisternae, are absent or rare in the atrial myocardium. And the myofibrils are made up of the contractile proteins, while each intercalated disc consists of 3 types of specialized cells. So this is a picture showing the unit of the myocardium. You can see the myofibrils, the transverse tubules that help in movement of calcium for contraction, the mitochondria, then the very specialized cells and the lines that we need to cram, the Z bands, the M lines, H lines, we'll see them later, and then the A bands. Okay, so this is just a branching myocardial fibers with striations. This is also still a picture of that. So the major contractile proteins are actually the myosin thick filament, the titin, the actin thin filament, the tropomyosin, the troponin T, C, and I. While the minor contractile proteins are the alpha actinin, the C protein, and the nebulin. So these proteins, they connect to each other and they interact to be able to cause contraction within the myocardium. So as we can see, they are very important structures to note. So I don't know if we can look at the different myosin filaments, the actin filaments, and where they meet. Then the titins are the anchoring filaments. They are all important in formation of diseases, especially when we begin to look at individual cardiomyopathies. They are important, and some of them are implicated in some of the cardiomyopathies, which we know. I'm coming just in a minute. Okay, so the myosin itself has 3 myosin isoforms. So we have the V1, which consists of sorry, excuse me. Okay. So there are 3 myosin isoforms, and this depends upon the electrophoretic mobility. So we have the V1 that consists of the 2 alpha myosin chain, and then the V3, which has the beta myosin chain, which are 2 betas. And then the V2, which has the alpha and beta myosin heavy chains. So this is also important when we're looking at the type of myosin heavy chains in fetal life and that in adulthood. So each of the myosin isoform is produced by different gene located on different chromosomes. So the V1 is on chromosome 3 and the V3 is on chromosome 14. So the V1 myosin isoform, it has some special properties. It has high ATPase activity, and it has fast shortening velocity but low efficiency of the tension, while the V3 myosin isoform has low ATPase activity with decreased shortening velocity but high efficacy of force production. Now, the characteristics of the V2 myosin isoforms are in between V1 and V3. So in the ventricle, in utero, until the late fetal life, V3 myosin isoform is the most abundant. And the V1 myosin isoform predominates only transiently shortly after birth. But thereafter, the beta myosin heavy chain becomes and remains as the most abundant, with 3 to 10% being the alpha myosin heavy chain. In the atria, V1 myosin isoform is predominant throughout life. And with increased workload, the ventricles can get switched to the V2 myosin isoforms, and the atria too can get switched to the V3 myosin isoforms when they are under pressure, like when you have a pressure overload or hypertrophy. So they can switch back to be able to safeguard their function. And we have the fibroskeleton of the heart. So we have the fibroskeleton of the heart. This is like the center structure of the heart, and it helps to support the heart tissues. And most of the heart tissues are anchored around it. So it's basically made up of connecting tissues that are around the valves. So we have the mitral valve, then the trigonum fibrosum dextrum, the tricuspid valve, the aortic valve, like we can see in the picture, and then the pulmonary valve. And then connecting the mitral valve and the aortic valve is the tendon of infundibulum and the trigonum fibronum sinistrum. Another important thing about the fibroskeleton of the heart is that the nerves that run through the heart can freely run through the fibroskeleton of the heart without being affected by any form of contraction. It protects and insulates them and prevents them from being damaged. And then, of course, it's an anchoring point for some of the tissues of the heart. So now we'll look at the heart valves. So the heart valves, there are 2 pairs of valves in the heart. So we have a pair of atrioventricular valves, which are the mitral and tricuspid valve, and then a pair of semilunar valves, which are the aortic and the pulmonary valve. So these valves help to maintain unidirectional flow of the blood. These valves help to maintain unidirectional flow of the blood and prevent its regurgitation in the opposite direction. So each cardiac valve has a central spongiosa and a peripheral fibrosa. Both the sides of the fibrosa are covered by loose fibroelastic tissue, usually containing mucopolysaccharides, and the entire valve is covered by endothelium. Now, the loose fibroelastic tissue on the atrial aspect of the AV valve is known as atrialis. The ventricular surface of all 4 valves, both the AV valves and the semilunar valves, it's called the ventricularis, and the aortic and pulmonary surfaces of the semilunar valves are known as the arterialis. Now, the endothelium and the loose connective tissue of the AV valves are continuous, and the atrial and the ventricular endothelium and those of the semilunar valves are continuous with the aortic and the pulmonary intima. Smooth striated cardiac muscles may extend into the proximal one-third of the atrialis and in the AV valves and often contain blood vessels. And the distal two-thirds of the AV valves and both semilunar valves are avascular. Now, the mitral valve consists of two leaflets, the anterior mitral leaflet, which develops from the superior and inferior endocardial cushions, and then the posterior mitral leaflet, which develops from the left lateral endocardial tissue. So this is a description of the valve, the mitral valve. So we have the annulus, which is saddle-shaped, about 4 to 6 centimeters in size, fibrous anteromedial portion, and a muscular posterior lateral portion. And then the leaflet sail-shaped, the anterior mitral leaflet is sail-shaped, and then the C-shaped scalloped posterior mitral leaflet. Now, the papillary muscles anchor the chordae tendineae that anchors the valve, and the papillary muscles are two, the anterolateral papillary muscle located at 4 o'clock position, and the posteromedial papillary muscle at 7 o'clock position. Now, the chordae tendineae are about 120 in number, and then they are cuspal. We have the primary, secondary, and tertiary. Then for the commissural on the leaflet, we have the anterolateral and posteromedial commissures. So this is a picture showing the mitral valve. We can see the papillary muscles, both the medial and the posteromedial and the anterolateral ones. Then we can see the annulus. We can also see the chordae tendineae, and then the leaflet itself, the posterolateral commissures and the anterolateral commissures. Now the tricuspid valve, the tricuspid Okay, so the tricuspid valve consists of the anterior leaflet from the right lateral and dextrodorsal endocardial cushion, while the posterior leaflets arise from the right lateral endocardial cushion, and the septal leaflet from the inferior endocardial cushion. So the tricuspid valve annulus is circumferential in shape, measures about 5 to 8 centimeters in size, and it has the anterior, posterior, and septal largest, the posterior, which is usually multiple, and the septal, which may be rudimentary. And then the chordae tendineae, it has 5 types: the fan-shaped, the rough, the deep, the basal, and the free edge. I think there's a picture on it later on, I'll show you. So this is just a picture showing the tricuspid valve. Okay, then the semilunar valves. The semilunar valves are derived from the truncus arteriosus and the truncal and the intercalated valve cushion. Sorry, I think the fetal development of the heart, the embryologic development of the heart should have come first so that we can be able to understand where all of this arise from. But I had already explained the endocardial tubes and how they are divided. So the topmost part is the truncus arteriosus, and that forms part of the semilunar valves. So the truncus arteriosus and the truncal and intercalated valve cushions make up the semilunar valves. The aortic and pulmonary valves are the ones which we call the semilunar valves because their cups are semilunar in shape. They are situated at the summit of the outflow tract of their corresponding ventricle, and the pulmonary valve is anterior, superior, and slightly to the left of the aortic valve. Now, each semilunar valve consists of an annulus, 3 equal-sized semicircular cusps, and then 3 equal-spaced commissures, and 3 sinuses of Valsalva. For the pulmonic valve, is located superior in the right ventricular triangle separating the right ventricle from the main pulmonary artery. A semilunar valve and 3 leaflets, right, left, and posterior. Now, the valve orifice is about 3 cm in diameter during systole, and the leaflets are thin and translucent. The nodulus areatis is a fibrous thickening at the midpoint of the free margin of the leaflet, and then the lunulae are crescent thickenings at the edge of the free margin of each leaflet. I think there's a picture in front concerning that. Okay, so I will look for it when we get there. Okay, so the aortic valve, it guards the outlet of the left ventricle, and it's a semilunar valve with 3 leaflets. So we have the right, which is the anterior coronary, the left posterior, and then the non-coronary, meaning that the right just means, okay, we'll see it later. So the right coronary, the left, and then the non-coronary, which doesn't produce the coronary arteries. The leaflet also have the noduli areatus, which is the folding at the free edge of the leaflet at the mid portion of the free margin. And then the sinuses of Valsalva are located at the aortic root, and the coronary originates from the walls that surround the sinuses. So the edge of the leaflet have fenestrations, significant for the small AR jets seen in 5% of normal individuals. So the annulus of the aortic valve. So the measurements are shown. I think we just need to move fast. We can look at them later. The leaflets, the sinuses of Valsalva, all of them are shown. We can read through later. So this is just a picture showing the aortic pulse. You can see the right, the left, then the non-coronary. So the right aortic pulse, just at the aortic sinus, will give the right coronary artery. The left will give the left coronary artery. Then the non-coronary pulse or sinus around there, it doesn't produce any artery. Okay, these are the different shapes. So we'll just go to the anatomy of the conducting system. So the conducting system consists of the SA node, the AV node, the bundle of His. So the SA node, the AV node, the bundle of His, the left bundle branch, the right bundle branch, and then the terminal Purkinje fibers. So the SA node is at the lateral junction of the SVC and the right atrium, while the AV node is at the apex of the Cox triangle, which we are going to see later. Then the bundle of His, which is a cord-like distal continuation of the AV node. Then the left bundle branch, which forms a cascade down the left ventricular septal surface. The right bundle branch, which is beneath the non-coronary aortic cusp, and direct continuation of the His bundle along the right side of the ventricular septum, and then the terminal Purkinje fibers on the endocardial surfaces of the ventricle. Okay, so we'll be looking at the sinoatrial node. So the SA node is a spindle-shaped structure. It's about 10 to 12 millimeters long and usually 1 millimeter thick. And it's important to note that it's situated in the subepicardium and less than 1 millimeter from the epicardial surface at the lateral junction of the superior vena cava and the right atrium. So the blood supply to the SA node is by the sinus nodal artery that arises from the proximal part of the right coronary artery. And this is in 55 to 60% of people, while in 40 to 45% of people is supplied by the left circumflex artery. And we can have supply from both the left circumflex artery and the sinus nodal artery in about 11% of people. So histologically, the sinoatrial node has 3 major cells. It has the P cells, which are the source of the normal impulse formation in the SA node. Okay, and these cells are ovoid, they are small, they're about 5 to 10 micrometer in greatest diameter, and they resemble the primitive myocardial cells. Then we have the transitional cells, which provide a functional pathway for the distribution of the sinus impulses formed in the P cells to the rest of the atrial myocardium. And they are intermediate between the P cells and the atrial myocardial cells. And then finally, we have the atrial muscle cells. Now we have the internodal tracts that connect the atrium. So we have the anterior internodal tract, which we call the Bachmann's bundle. We have the middle internodal tract, which we call the Weckenbach's bundle, and then the posterior internodal tract, which we call the Torel bundle. So the atrioventricular node is what we'll be looking at next. So the AV node is small, ovoid structure. It's smaller than the SA node. It measures about 1 times by 3 by 5 millimeters. It lies just beneath the right atrial posterior epicardium. Okay, and it's anterior to the ostium of the coronary sinus and directly above the insertion of the septal leaflet of the tricuspid valve. So the AV node is basically located at the apex of the triangle of Cox, which is formed by the tendon of Todara in front, by the base of the septal leaflet of the tricuspid valve, and the base by the ostium of the coronary sinus. So this is very important, especially when you're doing an EPS study or you're trying to do ablation for any of the AVNRTs. So it's important, it's an important landmark so that you don't get the AV node injured. So the turn of Todora originates from the semi-fibrous body, which we saw previously, and passes posteriorly through the atrial septum. Now, the AV node it has a compact part. The compact AV node becomes the penetrating bundle of His at the apex of the triangle of Cox and passes through the membranous interventricular septum below the point of the attachment of the tendon of Todora to the central fibrous body. Now, the blood supply is through the AV nodal artery, which is a branch of the right coronary artery in about 85 to 90%. And then once again, the left circumflex artery can also supply the AV node in about 10 to 15% of people. Now, histologically, the AV node has 4 types of cells. We have the P cells again, the transitional cells, the atrial myocardial cells, and what adds to it is the Purkinje cells. So if you're doing electrophysiology, the AV node can be divided into 3 regions: the AN region, the N region, and the NH region, which we can go through later. So the bundle of His, it's actually a cord-like distal continuation of the AV node. It measures about 20 millimeters in length and up to 2 millimeters in diameter. It is anatomically subdivided into 3 portions. So we have the proximal part that is non-penetrating, the middle part that is penetrating, and then the distal branching portion. So the proximal non-penetrating portion is just the portion distal to the AV node. Then the middle penetrating portion is tunneled into the fibrous tissue of the central body and the membranous septum. And then the distal branching portion is the His bundle that bifurcates at the crest of the muscular septum into the right and left bundles, immediately distal to the membranous ventricular septum. Now, the blood supply is from both the LAD and the PDA, and hence this portion of the conducting system is less subject to ischemic damage. So histologically, the His bundle primarily consists of the Purkinje cells. Now, the left bundle branch, it forms a cascade down the left ventricular septal surface beneath the non-coronary aortic curve. And the left bundle radiates in a fan-like fashion with 2 major divisions, the thin anterior superior and the thick posterior inferior fascicles. However, the study by Tarawa indicated that there may be a trifascicular division of the left bundle branch, but this is not yet confirmed. Now, the right bundle branch, it's the direct continuation of the His bundle and is positioned along the right side of the ventricular septum. The right bundle branch becomes a subendocardial structure in the middle lower thirds of the ventricular septum and remains unbranched at the apex of the right ventricle. Now, the terminal Purkinje fibers connect with the ends of the bundle branches to form interweaving networks on the endocardial surface of both ventricles. However, the Purkinje fibers tend to be concentrated at the tip of the papillary muscles rather than at the base of the ventricle. They are more resistant to ischemia than the common myocardial fibers. Okay, so this is just showing the blood supply. So the left bundle branch is supplied by both the LAD and the RCA. Now the anterior superior fascicle, 50% by the septal branch of the LAD and the AV nodal branch of the RCA, and the other 50% only by the septal branch of the LAD. Now the posterior fascicle, 50% the AV nodal branch of the RCA, 50% by both the AV nodal branch of the RCA and the septal branch of the LAD. And then the RBB, similar to that of the anterior superior fascicles of the LBB. Okay, so this is just a picture showing the conduction velocities of each part. Like we heard yesterday for the SA node is about 60 to 100 based on the pacemaker rate. And then the AV node about 40 to 55. And then the bundle of is 25 to 40. And then the bundle branches 25 to 40. And then the Purkinje network 25 to 40. Please, I'm sorry. My son has refused to go out. So cardiac anatomy, so that's the end. So the cardiac anatomy is essential towards understanding the basis of cardiac diseases, is fundamental in the diagnosis of congenital heart disease, even in adulthood, and also vital in the interpretation of cardiac imaging and cardiac devices. So thank you for your attention, and thank you, Dr. Amina, for helping with slides. All right, Dr. Godon, I'm done.
Thank you very much, Dr. Chineme, for such a detailed presentation. At this point, if you have any comments, contributions, please, you can raise your hand and then contribute to the discussion. I'm not seeing any messages in the chat box. If you have any comments, you can also type in the chat box, but it will be more appropriate to raise your hand and contribute. Thank you. So there's a comment from Peter Imba. He's saying, excellent presentation, Dr. Chineme. You're having a lot of appreciations also from Dr. Mohammed, Dr. Sori, Dr. Philothea. Yes, they're all congratulating you for the wonderful presentation.
Thank you. It's such a boring topic, but we'll just try to memorize it.
Okay, so if there are no contributions or comments, we move on to our facilitators. Please, Dr. Okopi, if you're on.
I am on, but my network has been quite poor. I just breathe in, breathe out, taking me up most times. I wonder why that keeps happening even, but money doesn't.
Sorry.
All right, so the floor is open for all our facilitators. Dr. Eugene, nice to have you. Any contribution? Dr. Alison and others at Ojo. Please, if you have anything, you can just unmute or raise your hand and then you'll be allowed to speak. But most appropriately, you can unmute and just speak. I must say thank you, Dr. Chineme, for a beautiful work. You did well. And if you, for those that have been to the exam, you'll see, I don't know currently now, but there are sessions in that exam, Anatomy of the Heart, where questions will come from here. I think you've done a great job, even though I couldn't follow through. So any contribution from anyone?
Yeah, good evening,
Dr.
Dr.
Eugene.
Kofi. Good evening, and good evening, everyone on the call. Unfortunately, I've been on the road, so I was listening in, but I couldn't pay much attention. But the parts that I listened to, I think she did an excellent presentation, and the deliveries were on point. The parts that I was able to follow. Thank you very much.
Well, thank you so much, Dr. Eugene. Thank you for your push. Thank you for being a great leader. All right, Dr. Gordon, we can continue the MCQ. Alison, you have something to say?
Yes. Good evening.
All right, good. Thank you.
Thank you, Dr. Kopi. Dr. Chineme, in fact, thank you so much. Thank you, and thank you again. The topic this aspect that she took is not actually easy making this presentation. But most of the things that she said are practically most of the things we will need. For the exam, when you are answering MCQs in exam, they are going to, just like you have curriculum topics, your MCQs are going to come from all aspects of the curriculum topic, and this anatomy aspects is not an exception. So, and the most important things, or maybe how the questions will be framed around, are the clinical correlates, you understand, of this anatomy. And well, just like she mentioned, embryology too would also be part of the correlates in these in the anatomy of the heart. She has not taken the coronary vessels. It's quite broad and elaborate. I quite agree with her. When I saw the topic, in fact, I was wondering how she was going to deliver that in one half. But Dr. Chineme, thank you so much. God bless you. What I would say
Thank you, Ma.
Yes, what I would say is we should please, the slides are simple enough, actually. I've also learned one or two things. So there are some landmark, what's the right word to say now? Landmark, like the Cox triangle. There are some things that she has mentioned. Cox triangle, I don't know. It's always coming out. I don't know. But just make sure you know the component, the floor, the borders, and all those things, and the clinical correlates of that is actually very important. The alignment of the blood vessels, where they are, and let me say where you find them, might also be important. Well, examiners have changed, but that came out in our own time. Then the location of the AV node, the SA node, all those things that she mentioned as regards the SA node, the AV node, please just note them. And also the conductive system too, reading them will be in correlation with, how do I put it now, with these arrhythmias. So I think the way she has put them, just learn them and know the clinical correlates. She didn't mention most of these clinical correlates, but if it's straightforward anatomy, bringing it out the way she has listed them, I think it's easy enough. So please, let's try and read it again, or pick some points from our slides. Well, that's what I would say. Thank you.
Thank you so much, Dr. Allison, for that comment. Very necessary and important. Dr. Gordon, we can revert back to our MCQ. Thank you, everyone, for coming. you can join us again for the MCQ. Let's hit the ground running.
Thank you very much, Dr. Kopi. So move on to our MCQ section. Please, the presenter for question 182. You can go ahead. So 182 was originally assigned to Dr. Selin Isian. If she's not on, then our backup person is Dr. Folorunso. Please, are you on?
Are you sure it's Folorunso or Mohammed? I think it's me. You know that I started the questions yesterday.
Yes.
Before, yes. So
thank you.
So we're starting question 183.
Okay.
Which of the following statements regarding lipoprotein A is not correct? So the options are A. One component of lipoprotein A is structurally identical to low-density lipoprotein, and another is similar to plasminogen. Option B, lipoprotein A levels do not vary significantly between racial groups. Option C, lipoprotein A levels vary little with changes in dietary fat intake. D, observational studies have associated elevated lipoprotein A levels with cardiovascular events. So for option A, it said that lipoprotein A it's related to LDL particle, specifically ApoB100, and then there's this is also covalently linked to apolipoprotein A that is similar to plasminogen. So this is a true statement. Option B, that makes it false. Option B, lipoprotein A levels do not vary significantly with between racial groups. This is a false statement because Africans are said to have higher median levels of lipoprotein A levels when you compare them to Asians and the Caucasians, who are said to have lower level. Despite the existence of these higher levels of lipoprotein A in Africans, the cardiovascular risk is still said to be almost the same between the groups, but Africans have higher lipoprotein A levels. So since this is a false statement, it's the true answer. So option B is true. Going to option C, lipoprotein A levels vary with changes in dietary intake. This is a true statement because it's minimally affected, like I mentioned earlier in the option B, that is the levels of lipoprotein A are determined by genetics and not diet. Option D, Observational studies have associated elevated lipoprotein A levels with cardiovascular events. This is also a true statement. So option B is the correct answer. I don't know if there's any clarification or question pertaining this question. Lipid lowering medication is not correct. A, fibric acid derivatives lower triglyceride, raise high density lipoprotein levels and may increase low density lipoprotein cholesterol. B, fish oil preparations raise triglyceride levels. C, other medications should not be taken within 1 hour before or within 3 hours after taking bile acid binding resin. D, ezetimibe added to statin therapy in patients with a recent acute coronary syndrome reduces subsequent coronary event rates more than statin alone. So for this question, we are looking for the wrong statement. So option A, fibric acid derivatives lower triglyceride and raise HDL and lower and increase low density lipoprotein cholesterol levels. This is a true statement because fibrates, an example of this is fenofibrate and gemfibrozil. They are effective in lowering triglyceride and increasing high density cholesterol levels. They may also increase LDL in some patients. Option B, fish oil preparations raise triglyceride level. So this is not correct. Fish oil, especially the ones that have ecosa pentaonic acid or docosa hexaonic acid, that's EPA or DHA, the lower triglyceride levels are not raised them. This they do by reducing the hepatic VLDL production, and this enhances the clearance of triglyceride. So this is the wrong option. So this is the true answer for question 184. But we'll go to option C so that we'll walk through it. Option C, other medications should not be taken within 1 hour before or within 3 hours after taking bile acid binding resin. Bile acid sequestrants like cholestyramine and binds to other drugs and impair their absorption. And it said that you should avoid taking any other medication within 1 hour or within 1 to 6 hours after taking the medication. So this makes the answer false. Option D, ezetimibe added to statin therapy in patients with recent acute coronary syndrome reduces subsequent coronary event rates more than statin therapy alone. this is true because the Improve It trial, where ezetimibe was combined with simvastatin, it was said to reduce cardiovascular events more than the statin therapy alone. So for this question, the wrong statement is option B, which talks about fish oil preparation raising triglyceride levels. I don't know if there's any question or clarification. Okay, we'll go to question 185. It's a long question. A 70-year-old man presented to the emergency department, ED, of a university medical center with multiple episodes of anterior sternal chest discomfort over the prior 2 days, each lasting 5 to 10 minutes in duration. He has this history of hypertension, exhibits elevated low-density lipoprotein cholesterol, and has been a regular cigarette smoker until stopping 4 months ago. He experienced a single transient ischemic attack 1 year ago. His home medication include aspirin 81 milligrams daily, atorvastatin 40 milligrams daily, and lisinopril 10 milligrams daily. The initial ECG was unremarkable, but while being evaluated in the emergency department, he experienced another 5-minute episode of chest discomfort, during which the ECG demonstrated transient 1 millimeter ST segment depression in the inferior leads in the inferior lateral leads 2, 3, AVF, V5, and V6. The initial high sensitive troponin T was 85 nanogram per liter. Reference range is 0 to 9 nanogram per liter. He received aspirin, IV unfractionated heparin, beta blocker, and high-dose atorvastatin therapies, and suffered no further chest pain. On examination, the blood pressure is 116/82 millimeters of mercury, heart rate is 72 beats per minute, jugular venous pressure is 6 centimeters of water, the chest is clear. Cardiac examination shows an apical S4 and no murmur. The abdomen is benign and there is no peripheral edema. No arrhythmias are observed on telemetry. 3 hours after presentation, the high sensitive troponin T concentration is 400 nanograms per liter. The serum creatinine is 1.11 milligrams per deciliter. Of the following approaches, which would be most appropriate? A, pursue a conservative strategy without invasive evaluation in the absence of recurrent ischemic symptoms. B, start Basogrel and pursue an early invasive strategy, coronary angiography within 24 hours. Initiate ticagrelor, increase aspirin to 325 daily, and follow a conservative strategy. D, do not add additional antiplatelets at this time. Pursue an early invasive strategy. So, looking at this question, sorry, I may need a bit of help here, but looking at this question, this patient still has typical angina symptoms. He presented with typical angina symptoms that have been ongoing for 2 days. ECG at presentation while being evaluated showed the transient ST segment depression in inferior lateral leads. The troponin increased from 85 at presentation to 400 nanograms per liter. this will meet the criteria for non-ST segment elevation myocardial infarction. Then he has a background history of a TIA, that's a stroke, and comorbidities like hypertension, smoking history, even though he stopped 4 months ago. It takes usually about 3 years, 2 to 3 years for the risks to that's for a smoker, for it to be similar for a non-smoker. Then he also has hyperlipidemia. So looking at this, I feel this patient will need coronary intervention. So torn between two options of B and D. So I'll need help with this one.
Okay, thank you. Please, any contributions?
I know that the current guidelines say that for non-ST segment elevation myocardial infarction, they should be on dual antiplatelets. Even if we are going to intervene, do a PCI, they should be on dual. So it's between B and D. I don't know if
Good evening. I think the answer, what is in the guideline? Like, well, patient with non-stem mine, you should start and see the coronary angiography before we start P2Y12 inhibitors. So I think from this question, it should be like we should first of all do angiography before we start P2Y inhibitor, which will most likely go for option D. I don't know if there's any other
Yeah. Good evening, everyone. Yeah, I think the option should be the do not add additional antiplatelet therapy, because we already concluded that this patient has that we are going to go for PCI for this patient. Although this patient has a non-stemmer, but he has other risk factors. There are other things that we should consider, like the Gracie score. He said that in the guideline, if the Gracie score is more than 140, there are other factors that should be considered. So this patient should actually have an invasive procedure like PCI. So, and we wouldn't want to give antiplatelet to, if this patient is going for PCI, it shouldn't have antiplatelet before it, so that there will be, so that we won't increase the risk of bleeding. So the patient should actually have it after PCI. So I think this should be the correct answer. Do not add additional antiplatelet therapy at this time. Pursue an early invasive strategy. That should be the correct answer. Thank you.
Yeah, I also agree that with the option. Good evening, everyone. I also agree with option D, because this patient has dynamic ST changes, so there should be an early invasive therapy, and it's actually a class 2A indication based on the ESC, is it 2021 or 2023? It's 2023 guidelines on management of ACS. And just like the last speaker said, yeah, even though it requires an early invasive therapy procedure, we shouldn't give antiplatelets. So of all the options listed, that appears to be the most appropriate. Thank you.
Okay, good evening, everybody. Please, I want to ask a question. I just discovered there's a very sharp rise in the high sensitive troponin, high sensitivity troponin T concentration from 85 nanogram to 400 nanogram per liter. Does it have any consideration in the urgency of the intervention? Please, thank you. Just a question.
Yeah, I think in early invasive, it means you should do it within 24 hours. So as long less than 24 hours, that's what early invasive strategy is. So it could be 1 hour, it could be 30 minutes, but it has to be done in less than 24 hours. So I think it is, even though there's a rise in the troponin and the patient, I think they said the patient was even given aspirin or something. I'm not sure now in the
Yeah,
it was
patient
given.
was given aspirin and IV unfractionated heparin.
So yeah, so it's I think the early invasive strategy is still appropriate, even with the rise in the troponin. So it could be anytime but less than 24 hours.
Okay, sorry, if I get the question correctly, from that rise, I think I've forgotten the score, but for you to make that diagnosis, there needs to be for a patient that already had troponin, elevated troponin, before you see it's acute. The rise from the initial level, there's a cutoff value that is used. So I think that's why the value it's necessary that from the 85 to 400. I'm trying to see if I can remember the exact cutoff value, but right now it's not coming.
Maybe I should just say, sorry, maybe I just say something so that we can move on. If you remember, there's a latest guideline, 2025 guideline for acute coronary syndrome diagnosis and management, which I think everybody should read. However, there's this fourth universal definition of acute coronary syndrome. You actually need, this is if it were to be ST segments, if it were to be STEMI now, it would have been easy to actually just make the diagnosis would be straightforward. Let me put it that way. But if it's STEMI, you are not sure, you don't have a baseline troponin of the patient. They talk about demonstration of either an elevation, maybe demonstration of an elevation from a baseline, or we call it like a reduction, yes, from the baseline, meaning that if you don't know the patient's baseline, patient comes with signs and symptoms, for instance, now, and you are thinking probably it's an MI, and you do a troponin, though high, but you are not sure if it's acute, if it's really acute, or maybe the patient has had elevated troponin before and patient does not have MI. You know, there are some instances that you have elevated troponin and patient does not actually at that time have acute coronary syndrome. So if you're able to demonstrate a rise from the baseline, that further substantiates your acute coronary syndrome, or there's a reduction from the baseline is MI. That's what the last speaker was trying to clarify. So not not an exact value, yes, for the troponin. The only thing that we need exact value for would be like you have to demonstrate a 99th percentile increase in troponin for that environment based on the lab, based on maybe the age and other criteria for the patient. So demonstration of the 99% percentile rather elevation would be able to maybe substantiate or definitely say the patient has an acute coronary syndrome. Having said that, for this question, you know, in a patient that has NSTEMI, we are looking for the next that's even the question I say the most appropriate thing to do in the patient. In a patient that has NSTEMI, the next most appropriate thing to do is for patient to have a PCI. That's just the correct answer. But the issue as to whether you have to use dual antiplatelets or not, you know, we are not talking about maybe you are doing conservative management here. You can't thrombolize patients. Any patient with NSTEMI, next best option is for the patient to have a PCI with stenting. So if the patient now cannot get to the center where PCI can be done within the stipulated time, then you consider conservative management while you transport the patients to the PCI center. You understand, either for rescue, salvage, depending on what the patient qualifies for at that particular time. So if they're not saying probably the time the patient cannot, they didn't tell you whether you can thrombolize in that facility or not, the next appropriate should be an invasive strategy. That's what I feel makes the D correct. And also we should note that if patient is to have PCI, there are some instances that you have to choose the class of antiplatelets, yes, to use. We should also note that when you use when you have Pasugrel contraindicated, when you can use Tigagrelor and also what's the name, Clopidogrel. No, now, but I think on the safer side, something that just, let me say, just cram for safety purposes in all of this, we know that the one that is commonly available in our environment, that's the Clopidogrel, is safe no matter what, you understand, across whatever you're doing for a PCI, conservatives and the like. Thank you.
Thank you so much, ma. And also, Pasugrel is also contraindicated in person that has already had stroke. Although they say this patient had transient ischemic attack, so I'm not sure whether it's also contraindicated in. But the patient that has already had stroke before cannot use Pasugrel. It's contraindicated in them.
Pasugrel is contraindicated in patients that are over 75 years, that has a body weight of less than 60 kilograms and has TIA or stroke. And in the Clarity TIMI trial, they found out that I've seen that generally, like our chief have said, there's no really preference for any antiplatelet, but they found out that clopidogrel seems to be, after PCI, clopidogrel seems to be more preferable than the other
Go and drop that thing. That thing is not tea.
Because they found out that it's in the Clarity team, they found out that it is safe and effective. It reduces cardiovascular death, reinfarction, and revascularization rate in the trial. So there's no really preference, but after PCI, clopidogrel seems to be more preferred. Thank you.
Yeah, hello, good evening. Sorry, on that note, I beg to differ. This usually. So post PCI, clopidogrel will not be your preference. I think we'll have an update on the recommendations and the guidelines. If you want to choose any antiplatelet, which is a P2Y12 inhibitor, the one that you can close your eye and choose, preferably is the ticagrelor. Antithrombotic benefit is there's evidence and also has lower bleeding risk compared to prasugrel. The problem with clopidogrel is that it's a prodrug. We should remember that. And there are some genetics with clopidogrel too. There are new recommendations even pushing for the use of only ticagrelor post-PCI. But as it stands now, most cath labs will do the aspirin with a P2Y12 inhibitor. The recommendation originally was for 2 to 12 months. Like stated in the chat, a prasugrel cannot be used for several reasons, especially if you don't know the coronary anatomy and also high bleeding risk, etc. So prasugrel generally is not preferred. Most often you'll be caught between clopidogrel and ticagrelor. Of the two, head-to-head, ticagrelor is preferred over clopidogrel as dual antiplatelet, unless the patient has a high bleeding risk or you are doing triple therapy, i.e., the person requires dual antiplatelet in addition to anticoagulation, for example, for an established DVT or a PE. In that sense, because the risk of bleeding with ticagrelor is higher than clopidogrel, triple therapy, the recommendation is to use clopidogrel. But if you have a PCI stent to do dual antiplatelet, ticagrelor and aspirin is recommended over aspirin and clopidogrel, considering bleeding risks being similar. Now, the original recommendation was to do 12 months of the dual antiplatelet therapy. But now, for some specific patients, based on bleeding risk, you can do 6 months. And even like I said, now the recommendation is pushing towards 3 months. The challenge of these recommendations in our environment is that these trials, they not use stents that we routinely use at this part of our region. Some of these trials use resorbable stents, etc. So it is difficult to just translate them into our environment where most cath labs are using probably first or at best second generation stents. So that's the caveat. But ticagrelor is preferred over clopidogrel and not the otherwise. Thank you.
Chief, thank you.
Thank you.
Please, any more contributions? If not, we'll move on to the next question. My only challenge is that although we've agreed on the fact that D is the answer, would it really be a problem if you do dual antiplatelet before the intervention? That's my concern. And I don't know if at the time this book was written, maybe the guidelines wasn't very clear compared to new guidelines. That suggests that you can actually do both before you do the intervention.
So just to come and go in, dual antiplatelet therapy in non-STEMI can be done, but it's not compulsory. The most significant one is the aspirin. This question, as stated, the answer by my senior Dr. Allison is not necessarily to focus on the antiplatelet, but to let you understand that this patient will need what? Revascularization. So don't let that part be, but you can use dual antiplatelet therapy in non-STEMI, but not as preferred if it's a STEM. You can forego the P2Y12 in a non-STEMI and go ahead with your cath lab. So there's pre-treatment with P2Y12 or no pre-treatment. For non-STEMI, the benefit of pre-treatment with the P2Y12 inhibitors is not absolute. So that is the emphasis on this question, is to push for early revascularization and not necessarily to push the idea that there's much benefit with dual antiplatelet for
Okay.
a non-STEM.
Thank you very much. Thank you. Okay. Please, any more questions or contributions before we move on to?
Sorry, please, I want to ask some questions. Chief, please, I'm asking, I know that this the guideline had something to do with if you have NSTEMI, to be able to like grade them into those that have high risks that will need revascularization, and then those that are not like high risks that will need to do the basic treatment that's not the revascularization, and then subsequently do an angio for them in the next 24 hours to see if they still require like a stenting, if there's narrowing of their vessels. So I'm asking, is that now out of the guideline that we don't need to classify based on high grade to be able to do a stent, know when to put a stent for NSTEMI, and when just to do a conservative therapy and then do a coronary angio in 24 hours to be able to know if we'll stent? As Chief was saying something about the new 2025 guidelines, so I'm just
So,
confused.
Chineme, if you look at the question, they had given you some information to help re-stratify this patient. Okay, they told you the ST changes were transient, hemodynamically patient is stable, and other parameters that can help you re-stratify this patient. At least, I've not done the calculation, but offered with the description of this patient with rise in troponins from baseline going up, this patient will be around high risk. And now for high, so you have very high risk, and low risk, or some would say intermediate risks. For very high risk, you treat them like a STEMI equivalent. It means you go to the cath lab within 2 hours. For high risks, you have 2 to 24 hours to go to cath lab to do the coronary angiography plus or minus PCR. Remember, it's not every patient that you do coronary angiography that you may be able to stent. So it's coronary angiography plus or minus PCR. Revascularization is not absolute because you've gone to the cath lab. You may go in and see a triple vessel disease or have a lesion that is bifurcation that you can't stent, dependent. So it's the low risk patients that the recommendation was to do a diagnostic angiogram if feasible before discharge. But for high risk, you have 2 to 24 hours. Very high risk was within 2 hours, just as a STEMI. So I had a colleague mention some of the risk stratification tools earlier when I was driving. There's a gray score, there's hemodynamic stability, refractory to chest pain or persistent ST changes, and hemodynamic instability, new MR, etc. So there are parameters that help you to risk stratify the patients into these categories. Then that will inform how fast you send to the cath lab for coronary angiography. Like Dr. Allison said, if you've established myocardial infarction according to the fourth universal definition of MI, it means that this patient you are saying that has an obstructive coronary artery disease, which has to be looked at. The question is how soon? So how soon is dependent on the risk of the patient based on your risk stratification. Thank you.
Okay, thank you, Chief. So what I'm asking is, has it changed in the 2025 guidelines that Chief Allison said there's a 2025 guidelines? I've not read it. So I'm asking if it has changed or is still the same. I was trying to find out if it has changed or we are still using the same thing, or are there new things in the 2025 guideline concerning NSTEMI? Or Ma, please, if you have it, you can drop it on the platform so that we can look at it.
Let Chineme share it, but there's not much difference. What Eugene is saying is actually absolutely true. Yeah.
It's
So
still
Chineme should just share it. You'll see it there.
Chief, I don't have it. I'm pleading with Dr. Allison to share it. Thank you.
I mean, Dr. Allison. Yeah.
Thank you. Thank you, Dr. Eugene. Thank you.
Okay, thank you very much.
Dr. Gordon can hit the ground.
Okay, thank you. So question number 186. Dr. Mohammed, please, if you can go on. Hello, Dr. Mohammed.
Okay. Question 186. Okay, which of the following statements regarding secondary prevention of non-cardioembolic ischemic stroke is correct? Hypertension should not be a target of secondary prevention after an ischemic stroke because elevated blood pressure is necessary to maintain adequate cerebral perfusion. This is false. It said that for secondary prevention, we should target BP of 130, less than 130 over 80 millimeters of mercury. Option B, compared with aspirin, chronic warfarin therapy reduces the risk of recurrent stroke. This is false. The WAS trial and WASID trial said there was no difference between aspirin and warfarin use in non-cardioembolic stroke. And the warfarin had increased risk of bleeding. So that's false. Option C, for patients with minor stroke or high-risk transient ischemic attack, the risk of recurrent ischemic stroke is reduced by a combination of aspirin with clopidogrel for 21 to 90 days, followed by single antiplatelet therapy. We'll come back to that, sir. Option D, the long-term combination of aspirin plus clopidogrel is superior to aspirin alone for the prevention of recurrent stroke. I'll also come back to this. Option E, clopidogrel monotherapy is superior to aspirin plus dipyridamole for secondary prevention of stroke. So for the clopidogrel monotherapy being superior to dipyridamole is false because the PROPHET trial found no significant difference between clopidogrel monotherapy and aspirin plus dipyridamole. So option C and D, it was found that combination of clopidogrel and aspirin for 21 to 90 days reduce the risk of recurrent stroke. However, use after for duration more than 90 days increase the risk of bleeding. So the duration for use of dual antiplatelets after a stroke is said to be it should be between 21 to 90 days before switching to single antiplatelet. So for this question, option C is the correct answer. Dual antiplatelets for 21 to 90 days, followed by single antiplatelet therapy. I don't know if there's any contribution or question.
Okay, please, if there are no contributions, we can move on.
Okay, question 187. Which of the following statements regarding the relationship between alcohol and coronary artery disease is not correct? A, moderate alcohol intake, 1 to 2 drinks daily, is associated with lower incidence of coronary heart disease than in no alcohol intake. B, alcohol consumption reduces platelet aggregation. C, heavy alcohol intake is associated with an increased cardiovascular mortality. D, alcohol lowers low density lipoprotein levels. E, alcohol raises high density lipoprotein levels. So for this question, we're interested in the wrong option, the statement that is not correct. So going through it, option A, moderate alcohol intake 1 to 2 units daily is associated with lower incidence of coronary heart disease than in no alcohol. There's a J-shaped relationship between alcohol intake and coronary artery disease. And it said that moderate intake is associated with lower coronary artery disease. And the mechanism through which this occurs is that moderate alcohol intake increases the level of HDL and reduces platelet aggregation. And it also improves insulin sensitivity. So this statement is correct. So it's false. Option B, alcohol consumption reduces platelet aggregation. I had mentioned that as one of the mechanisms earlier. So this is also a true statement. So it's false. Option C, heavy alcohol intake is associated with an increased cardiovascular mortality. This is true. Remember, I mentioned that the relationship is J-shaped, so it's not a linear relationship where you say the more the alcohol intake, the more the protection of the heart. So the mechanism where heavy alcohol is associated with increased cardiovascular mortality is heavy alcohol intake can predispose a patient to arrhythmias, and chronic alcohol exposure can also predispose patients to development of things like dilated cardiomyopathy. And this would, coupled with the risk of arrhythmias, will increase the overall cardiovascular risks. So that is also a true statement. So it's false. Option D, alcohol lowers low density lipoprotein, LDL. This is a false statement, so it's true. Alcohol does not lower LDL levels. It said that moderate levels of alcohol intake increase the level of HDL, but it doesn't have necessarily effect of lowering the LDL level. So this is the correct answer. That's it's a false statement, so it's true. Option E, alcohol raises high density lipoprotein level. I had mentioned that earlier, so this is a true statement, so making it false. So for this option, the false statement is option D. I don't know if there's any question or we can go ahead. Question.
I think we can go ahead.
Okay. Can't see. Can you scroll up a bit, sir? So question 188. Which of the following statements regarding smoking cessation is not correct? A, smoking cessation reduces the risk of coronary event by 50% within 2 years. B, patients who continue to smoke after a myocardial infarction have twice the mortality rate of those who stop smoking. C, patients who successfully quit usually do so after 5 or more unsuccessful attempts. D, physician counseling is as effective as pharmacologic aids in achieving smoking cessation. So for this question also, we're looking for the wrong option. So for smoking cessation, it said that within 2 years, the risks compared to a non-smoker, it's said to reduce by 50%. And after 3 to 5 years, a smoker who has completely stopped smoking within for between 3 to 5 years has same risks as a patient who never smoked. So this is a true statement, so that will be false. Option B, patients who continue to smoke after a myocardial infarction have twice the mortality rate of those who stop smoking. Sorry, I'll come back to that. Patients who successfully quit usually do so after 5 or more unsuccessful attempts. Question. Okay. Yeah. A bit stuck, but
Hello, Mohammed. You say you're stuck
yeah.
on something?
Yes, I'm just stuck this particular question.
Hello?
Do you want others to contribute?
Yes, if they can, while I gather my thoughts.
Oh, okay. Thank you. Please, any contributions on question 188?
Hello? You're stuck on what?
Okay, question.
Can you guys hear me?
Yes, we can hear you, sir.
I lost him. I don't know where he is. What question was it?
Question 188, sir. Okay, Dr. Gordon.
Yes, please.
Option B, patients who continue to smoke after myocardial infarction have twice the mortality rate of those who stop smoking. That's also a true statement, so that makes it false. C, patients who successfully quit usually do so after 5 or more unsuccessful attempts. This is also a true statement because nicotine addiction is usually nicotine is quite addictive. So most patients who are smokers find it difficult in quitting, and that's why they are most times apart from the psychotherapy, there are also pharmacotherapy, use of drugs like varenicline for addicts, and then nicotine substitutes or cigarette substitutes like nicotine gum and nicotine patch, even though there's a debate about the efficacy of the gum and the patch. Option D, physician counseling is as effective as pharmacologic aids in achieving smoking cessation. This is a false statement because, like I said earlier, nicotine is quite addictive. So most times just psychotherapy is not sufficient in aiding patients in stopping cigarette smoking. There's usually need for pharmacotherapy using drugs like bupropion and varenicline. So for question 188, option D is the first statement. That's and the true answer. Question 189. Which of the following statements regarding exercise training and rehabilitation of patients with coronary artery disease is true? A, home programs should emphasize bursts of exercise to the onset of marked dyspnea. B, augmented cardiac output exercise is due more to an increase in stroke volume than an increase in heart rate. C, during exercise, increased myocardial oxygen consumption is provided more by an increase in augmented oxygen extraction by coronary blood flow. D, exercise-based cardiac rehabilitation participation is associated with lower mortality rates. E, approximately 80% of the improvement in exercise performance with physical training is due to increased cardiac output, and 20% to peripheral adaptations that improve oxygen extraction. So, can you scroll to the beginning of the question? So for this question, we are looking for the true option. So I'll start with E. Let me start with the ones that are obvious. Option E, approximately 80% of improvement in exercise performance with physical training is due to increased cardiac outputs, and 20% to peripheral adaptations. This is false because it said that both the cardiac outputs and peripheral adaptations are responsible for 50% each of the improved oxygen extraction. So that is false. Option D, exercise-based cardiac rehabilitation participation is associated with lower mortality rates. For now, I will go with that option D as the true statement. During exercise, increased myocardial oxygen consumption is provided more by an increase in augmented oxygen extraction than by coronary blood flow. This is false because both the augmented, the cardiac output and the coronary blood flow, the peripheral adaptations and the coronary blood flow are responsible for 50% each. So that should be false also. Option B, sorry, Eugene, can't see B. Option B, augmented cardiac output during exercise is due more to an increase in stroke volume than an increase in heart rate. This is false. During exercise, it's the outputs. It's more about at the initial phase, the heart rate is the main contributor to the increase in cardiac output. So this is a false statement. Option A, home programs should emphasize bursts of exercise to the onset of marked dyspnea. This is also a false statement because it said that for rehabilitation, exercise should be graded and not done in bursts. So that is also a false statement. So the true option is D. The true statement is option D. Question 190. Which of the following statements regarding homocysteine is not correct? A. Inherited defects of methionine metabolism may cause extremely high serum levels of homocysteine and premature atherothrombosis. B. Polymorphisms in the methylene tetrahydrofolate reductase gene are associated with an elevated homocysteine level. C. Epidemiologic studies have linked mild homocysteinemia with an increased risk of coronary events. D. Folic acid and other vitamin B supplements reduce serum homocysteine levels. E. Dietary supplementation with a combination of B vitamins, folic acid, B6, and B12 reduce the risk of atherothrombotic events. So for this question, we're looking at the first statement. So option A, inherited defects of methionine metabolism may cause an extreme high level of homocysteine and premature atherosclerosis. This is the true statement. The metabolism of homocysteine, it usually involves dietary methionine, and inherited disorders will cause high levels of homocysteine and homocysteinuria. So this is a true statement. So that since we're looking for the first statement, that makes it false. Option B, polymorphism of methylene tetrahydrofolate reductase gene is associated with elevated homocysteine levels. So the enzyme deficiency, the enzyme deficiency of methylene tetrahydrofolate reductase, it's said to be associated with elevated homocysteine levels. So this is also a true statement. Epidemiologic studies have linked mild homocysteinemia with an increased risk of coronary events. This is also true. Because this is said to be one of the non-traditional risk factors of coronary artery disease. Option D, folic acid and other vitamins B supplements reduce serum homocysteine levels. This is also true because folic acid plays a key part in the metabolism of methionine to form homocysteine. Option E, dietary supplementation with combination of vitamin B vitamins. A combination of B vitamins, that's folic acid, B6 and B12, reduce the risk of atherothrombotic events. Studies have shown that despite the fact that folic acid is plays a key part in the metabolism of um, so looking at the false, so this makes it the true statement, the true answer, the answer for this question, since we're looking for the false option. So question 190, I'll go with E as the answer. Hello. I don't know if anybody has any question or any clarification.
Thank you. Any questions? If there are no questions, we'll move on to the next set of questions.
Hello, good evening.
Good evening.
My teachers and my name is Faith Chicken. I was assigned question 191 to 195.
Thank you.
Okay, so
You can go ahead.
question 191. Which of the following is not a component of the atherogenic metabolic syndrome? Okay, this question is trying to test our knowledge of the components of metabolic syndrome and various cutoffs or criteria to make a diagnosis. So looking at the options, metabolic syndrome is a constellation of risk factors that increase the risk of adverse cardiovascular events. There are some underlying abnormalities in metabolic syndrome, one of which is insulin resistance. So there are also other components of it like hypertension, dyslipidemia, obesity, and all. So in 2009, there's a joint definition published by the International Diabetes Federation American Heart Association, and others. So it says that metabolic syndrome is present when you have 3 or more of the following. There's hyperglycemia, which is fasting plasma glucose of 110 milligram per dl or more. When you have abdominal obesity, which is assessed by measuring the waist circumference of men and women, this waist circumference is found in some ethnic region and ethnic variations. But for most people, for men, the waist circumference of more than 85 to 102 cm in men, and then waist circumference of more than 80 to 90 cm in women. But for us Africans, from when I tried to search, I found that for men, you have more than 90, and then for most studies is 94 cm in men, while for women it's still more than 80 cm, which is also in the range that is generally acceptable. That is for men more than 85, and for women more than 80 to 90. Okay, the other component is hypertension, when you have systolic blood pressure of greater than or equal to 130, and or diastolic blood pressure of greater than or equal to 85 millimeters of mercury. For serum triglycerides, when you have more than or equal to 150 milligram per dl, and also low high density lipoprotein cholesterol of less than 40 milligram per dl in men and less than 50 milligram per dl in women. So looking at the options, plasma glucose of more than 110 milligram per dl and metabolic syndrome, the heterogenic. Then B option, elevated serum triglycerides more than 150 milligram per dl is also a component. C, abdominal obesity, as described by the waist circumference, like I've said before, is also a component of metabolic syndrome. Then option D, serum low density lipoprotein greater than 140 milligram per dl. This is not a component. The component, the lipid part of this metabolic syndrome has to do with the triglycerides and then the high density lipoprotein cholesterol, not low density lipoprotein cholesterol. So this is actually the answer to the question. Then hypertension, like I've said before, of systolic blood pressure greater than 130 or diastolic greater than 85 millimeters of mercury. So for this question 191, the correct answer here is option D. Okay. Question 192. A 52-year-old woman presents for outpatient management. She is interested in non-pharmacologic approaches to blood pressure reduction. Which of the following statements is true? A, acupuncture is an effective modality to achieve long-term blood pressure reduction. B, biofeedback methods that teach individuals to breathe more rapidly are effective for lowering blood pressure. C, garlic supplementation stimulates angiotensin II production and raises blood pressure. D, the DASH diet can lead to a sustained 10 millimeters of mercury decline in systolic blood pressure. Okay, the non-pharmacologic approaches to blood pressure reduction include, these are complementary or alternative ways to reduce or treat hypertension, in addition to the usual traditional lifestyle modifications that we know, including diet, cigarette smoking, cessation, alcohol moderation, activities and all that. So these other complementary approaches like acupuncture, few studies that studied the effect of acupuncture on blood pressure lowering in hypertensives. There were few, and then they showed an acute but non-sustained reduction in blood pressure. But most of those studies, the evidence is really inconclusive. So, and then the quality of the data were not that wonderful. Okay, so it causes an acute and then non-sustained. So looking at this option A, acupuncture is not an effective modality to achieve long-term blood pressure reduction. Okay, option B, biofeedback methods. Slow breathing increases parasympathetic activity with a reduction in overall sympathetic activation. This will lead to a decrease in the vascular tone and then help in reducing the blood pressure. So there's this device-guided biofeedback mechanism that teaches or helps the patient to breathe slowly, and it's been shown to have a significant effect on BP reduction. But from the studies, meta-analysis of some of the studies that showed these results, there were variations in the result, but one thing is common: it has a significant BP reduction. So what it causes is slow breathing, not a rapid breathing. The biofeedback mechanism uses slow breathing, not. So looking at this option B, biofeedback methods that teach individuals to breathe more rapidly are effective for lowering blood pressure. This is false. Option C, garlic supplementation stimulates angiotensin II production and raises blood pressure. Garlic supplementation, it contains a compound that is called allicin, which inhibits angiotensin II production, thus leading to vasodilatation and thereby reducing blood pressure. From studies done, it's found that a systolic blood pressure reduction of about 9 millimeters of mercury and diastolic blood pressure reduction of about 3.8 millimeters of mercury can be achieved with garlic supplementation, but it has to be at a dose of 600 to 900 milligrams. So looking at this option, it inhibits angiotensin II production and not stimulates. So this is a false statement. Then the D option, the DASH diet can lead to a sustained 10 millimeters mercury decline in systolic blood pressure. DASH diet is a dietary approach to stop hypertension. It emphasizes consumption of fruits, vegetables, low fats, dairy products, with low intake of saturated fats. It's been found to reduce systolic blood pressure by about 10 millimeters of mercury and diastolic blood pressure by 5 millimeters of mercury among people who are hypertensive. So looking at this option, looking at this question, D option is actually a true statement. Okay. Question 193. Clinical trials of which of the following dietary interventions have not shown significant improvements in coronary artery disease endpoints? A, Mediterranean-style diet supplemented with alpha-linolenic acid-enriched margarine. B, Mediterranean-style diet supplemented with extra virgin oil or nuts. C, low carbohydrate, high protein, high fat diet, example, Atkins-style diet. D, regular fatty fish or fish oil consumption. Okay, this question is testing our knowledge of clinical trials carried out on effects of diet on reducing cardiovascular events. The Mediterranean-style diet is a diet that is rich in fruits, legumes, vegetables, fiber, but it have reduced meat and butter and then cream. But according to this particular study, the Lyon Diet Heart Study, it enriched this Mediterranean-style diet with linolenic acid. acid-enriched margarine. So there was a study looking at the endpoint of the study, of the Lyon Heart study, was to look for a reduction in all-cause mortality and non-fatal AMI in people who are placed on this diet or on those who are placed on another control diet. Okay, that's people who already have coronary artery disease. And it was found that people on this Mediterranean diet and enriched margarine were found to have significant reduction in all-cause mortality and non-fatal MI when compared with the control group. Another study also, so looking at this first option A, it is a true statement. It has been shown to have significant improvement in coronary artery disease endpoints. Then option B, Mediterranean style diet supplemented with extra virgin oil, olive oil or nuts. Okay, another control trial, randomized control trial, PREDIMED, it compared a Mediterranean style diet that is enriched with olive oil and then another controlled another group for another diet for a control group. But in that one, they had control diet and then just dietary advice to reduce fat intake. It was found, this was tested in a group of people who have no known cardiovascular disease, but already have increased risk for cardiovascular diseases. So it was found that those who were on this enriched diets had fewer cardiovascular events than in the control group that had control diet and dietary advice only. Also, some randomized control trials of regular fish intake, and then those who take fish oil that is supplemented with EPA, eicosapentaenoic acid, and docosahexaenoic acid, respectively. They were found to have reduction in mortality in coronary artery disease compared to those who took regular fatty fish consumption. So looking at the questions, you see that the Mediterranean style diet with extra olive oil was shown to reduce to cause improvement in coronary artery disease. Also, the regular fatty fish or fish oil consumption clinical trial also showed an improvement in cardiovascular coronary artery disease endpoints. But this Atkins style diet is a popular approach for weight loss. It has been around for some time, but this diet is often associated with ketosis. It emphasizes restricting carbohydrate intake while allowing generous intake of protein and fats. So it's been shown to cause weight loss, increase high density lipoprotein cholesterol, and low triglycerides. But when compared to those who take low calorie, high carbohydrates, and low fat diets, but no randomized control trial has shown that it reduces cardiovascular events. So this D option, the regular fatty feed, this C option, that's low carbohydrates, high protein, high fat diet, that's the Atkins style diet. No randomized control trial have shown that it improves coronary artery disease endpoints. So looking at this question 193, C is the correct answer. Okay, then question 194. Which of the following statements about pharmacologic therapy for secondary prevention of coronary artery disease is not correct? Long-term aspirin use after myocardial infarction reduces cardiovascular mortality, reinfarction, and stroke rates. B, after myocardial infarction, beta blocker therapy reduces mortality over the next 2 years. C, angiotensin-converting enzyme inhibitors administered after myocardial infarction confer an early mortality reduction only in patients with left ventricular dysfunction. D, administration of HMG-CoA reductase inhibitors, that's statins, reduces cardiovascular deaths after myocardial infarction in patients with average cholesterol levels. E, after an acute MI, intense lipid lowering with a high-dose statin confers better clinical outcomes compared with only moderate lipid lowering. Okay, option A, long-term aspirin use after MI, reinfarction and stroke rates. Yes, aspirin as an antiplatelet agent has proven efficacy both in the acute and long-term management of MI. At the initial phase of acute myocardial infarction, aspirin is one of the medications that is administered. And then in the secondary prevention of acute MI, just like we discussed not long ago, aspirin is used for secondary prevention. Then, so looking at this option, it is a true statement, so that's not our answer. Then option B, after myocardial infarction, beta blocker therapy reduces mortality over the next 2 years. Yes, beta blocker use following an acute MI was found to reduce long-term mortality in about 23% of patients from studies done. And following PCI for ST elevation myocardial infarction, the American Heart Association supports the use of a beta blocker up to 2 to 3 years after myocardial infarction if there are no contraindications. So this is a true statement. Option C, angiotensin-converting enzyme inhibitors administered after MI confer an early mortality reduction only in patients with left ventricular dysfunction. This is a false statement. During and even after hospitalization of patients with myocardial infarction, AC inhibitors was found in clinical trials to reduce morbidity and mortality during and even after the acute events, irrespective of the left ventricular function of the patient. It was found that the greatest benefit was seen in the first week following the myocardial infarction, especially in patients who are high risk. So the benefits that it confers is both for those with left ventricular dysfunction and those without ventricular dysfunction, but the highest benefit is for we're seen in the first week, okay? And then it has been shown to have a 20 to 30% relative risk reduction in mortality over 3 years of follow-up. So option C is a false statement, not only for patients with left ventricular dysfunction. Then option D, administration of statins reduces cardiovascular deaths after myocardial infarction in patients with average cholesterol levels. And some studies done, it compared the effect of statins in patients with for secondary prevention in patients who had MI and then had both elevated cholesterol levels and also average cholesterol levels. And for both arms, statins demonstrated a reduction in cardiovascular deaths and myocardial infarction in these patients. Okay, and also there's a study, Prove It TIMI 22, which assessed the effect of statins, high-intensity statin or high-dose statins in patients with acute coronary syndrome. It was found in the study that high-intensity statins, example, atorvastatin 80 milligram daily, shows superior long-term outcomes when compared to less intense statin therapy like pravastatin 40 milligrams daily. So this option D is also a true statement. Option E, after an acute MI, intensive lipid lowering with a high dose statin confers better clinical outcome compared with only, okay, this is what I've described now. And then option, so what I just explained now explains both option D and E. So looking at this question 194, C is our answer. It is not correct. Question 195. Which of the following statements regarding heterozygous familial hypercholesterolemia is correct? A, it is a relatively common disorder with a gene frequency of at least 1 in 500 persons in the population. This is a true statement. It is familial hypercholesterolemia is familial hypercholesterolemia is commoner in the population when compared to the heterozygous form is commoner in the population when compared to the homozygous form. The heterozygous form of familial hypercholesterolemia is found 1 in 500 persons when compared to the homozygous form, which is found in 1 in 1 million persons in the population. The homozygous form is rare. Tendons and tumors are rare. Tendons and tumors are not rare in heterozygous familial hypercholesterolemia. Is common and is seen in the tendons of the Achilles tendon and also the other extensor tendons in the upper limb and lower limb. Option C, cutaneous planar xanthomas are common. This is a false statement. It is not common in a heterozygous form. Rather, it is seen in the homozygous form. It occurs in this homozygous, in patients with homozygous familial hypercholesterolemia, usually before 6 years of age, and is seen in areas of trauma. Option D, the fundamental defect is the presence of only 1/4 of the normal number of low-density lipoprotein surface receptors. Familial hypercholesterolemia is an autosomal co-dominant condition in which, for those who have the heterozygous form, they inherit one mutant gene that encodes the low-density lipoprotein cholesterol receptors. They inherit one mutant gene and one normal gene such that they produce half normal number of low-density lipoprotein surface receptors. While the homozygous form, they inherit both mutant genes such that they don't produce any normal surface low-density lipoprotein surface receptors. So this option D is a false statement. It's half of the normal number of low-density lipoprotein surface receptors that is produced by the heterozygous form when compared to the homozygous form. Thank you. So looking at this question, A is a true statement. Thank you.
Okay, good evening, my chiefs and colleagues. I'm taking question 195 to 200. So question 196 to 200. So for 196, so which of the following is characteristic of familial hypertriglyceridemia? Option A, plasma low density lipoprotein is usually high. B, plasma triglyceride levels can rise to as high as 1000 milligrams per DL after a meal. C, plasma high density lipoprotein cholesterol is usually increased. D, it is accompanied by a threefold increased incidence of atherosclerosis. E, hypertriglyceridemia is usually manifest in childhood. Just an overview of hypertriglyceridemia. It is not associated with clinical signs such as corneal accus, xanthomas, and xanthelasma, unlike seen in patients with familial hypercholesterolemia. Usually in patients with hypertriglyceridemia, they have elevated levels of triglycerides, very low density lipoprotein, and low levels of HDL and LDL. However, total cholesterol is either normal or mildly elevated. Usually, the fasting plasma total cholesterol concentration in patients with hypertriglyceridemia usually ranges between 2.3 to 5.7 millimoles per liter, which is equivalent to about 200 to 500 milligrams per day. Said that after a meal, plasma triglyceride level may rise to as high as plasma cholesterol level may rise to as high as 1,000 milligrams per DL. And it is thought that they said that alcohol, high calories, and carbohydrates usually stimulates increase or causes increased level of triglycerides. It has a weak relationship with coronary artery disease. So hypertriglyceridemia tend to have a weak relationship with coronary artery disease than familial combined hyperlipidemia. What leads to hypertriglyceridemia is caused as a result of hepatic overproduction of VLDL. It's an autosomal dominant disorder characterized by elevated level of serum triglycerides, like I said earlier on. Another thing we also want to know about it is that it, like I said, is inherited via autosomal dominant pattern. Is exacerbated by consumption of alcohol, caloric intake, carbohydrate diet, insulin resistance, even patients with hypothyroidism. Then usually children that have this condition are asymptomatic until late childhood or until their late teens, teenage age, and adulthood. The treatment is usually to restrict fats and caloric intake outside use of medications. So for question 196, we'll go back to the question now. Which of the following is characteristics of familial hypertriglyceridemia? Option A, plasma low density lipoprotein is usually high. That's the first statement. We're looking for the true statement here. I mentioned earlier that triglyceride level and VLDL are elevated, while HDL and LDL are low. So option A is wrong, because in patients with this condition, LDL levels are usually low. Then option B, plasma triglyceride levels can rise to as high as 1,000 milligrams per DL after a meal. This is the first statement, because I mentioned that for these patients, you can mention that for these patients, sorry, this should be a true statement. I mentioned that for this patient, plasma triglyceride levels can rise as high as 1,000 milligrams per DL after a meal. Then option C, plasma high density lipoprotein is usually increased. I mentioned that HDL and LDL are low. So option C is saying HDL is increased. So option C is wrong. For increased incidence of atherosclerosis, atherosclerotic cardiovascular diseases. Then option E, hypertriglyceridemia usually manifests in childhood. That's the first statement. Usually seen from the teenage age to adulthood. So for question 96, the correct option is B. Plasma triglyceride levels can rise to as high as 1,000 milligrams per dl after a meal. The other options are wrong. So question 97, which of the following statements about coronary stent thrombosis is not correct? A, the strongest predictor of late stent thrombosis is premature discontinuation of dual antiplatelet therapy. So which of them is not correct? A, the strongest predictor of late stent thrombosis is premature discontinuation of dual antiplatelet therapy. B, the risk of bare metal stent thrombosis is greatest 2 to 6 months following implantation. Sorry, can you take it up a little, Dr. Gordon? Okay, thank you. C, newer generation drug-eluting stents exhibit lower rates of stent thrombosis than bare metal stents and first generation drug-eluting stents. D, late stent thrombosis is more likely to occur in individuals with diabetes or renal failure than in patients without these conditions. As an overview, stent thrombosis is said to be an uncommon, however, it's potentially devastating and complication of coronary stenting. Acute stent thrombosis is said to, it can be divided into acute stent thrombosis, subacute, and late stent thrombosis. Acute stent thrombosis is said to occur if this thrombosis occurs immediately following the procedure, immediately following stenting, passage of a stent. While subacute is when it occurs within 1 month of passing a stent. While late stent thrombosis is said to occur if the thrombosis occurs after about 1 month of passing the stent. It is usually prevented by combining a P2Y12 receptor antagonists like clopidogrel, prasugrel, ticagrelor, and aspirin. The risk of thrombosis is greatest within the first month after implant. For bare metal stents, the risk of thrombosis is greatest within the first month of after implantation. And he said that newer generation drug-eluting stents manifest lower rates of stent thrombosis than bare metal stents and first generation drug-eluting stents. So the newer drug-eluting stents are usually recommended for PCI. And also, the strongest predictor of stent thrombosis is the strongest predictor for stent thrombosis is premature discontinuation of antiplatelet therapy. Other predictors of stent thrombosis includes if you place the stent in a small vessel or using a long stent, overlapping stents, multiple patients that have multiple lesions, ostial bifurcation, patients that have renal failure or low ejection fraction. So go back to the questions now. So question 197 says which of the following statements about coronary stent thrombosis is not correct? So option A, the strongest predictor of late. Hello?
Dr. Faith, please, we can hear you. So if you can turn off your mic.
Okay, thank you. So which of the following statements about coronary stent thrombosis is not correct? Option A, the strongest predictor of late stent thrombosis is premature discontinuation of dual antiplatelet therapy. This option is wrong because they mention here that the strongest predictor of late. The correct thing from what I said is that the strongest predictor for stent thrombosis is premature cessation of antiplatelet therapy. Is not strongest predictor of late stent thrombosis. Generally, strongest. These are strong predictor. Discontinuation of dual antiplatelet therapy is a strong predictor of stent thrombosis. It doesn't have to do with whether it's early or late. So option A is wrong. Then B, the risk of bare metal stent thrombosis is greatest. Okay, sorry. Option A is correct rather. So whether it's late or early, it's these are predictor. Discontinuation of dual antiplatelet therapy is a predictor of stent thrombosis. Then option B, the risk of bare metal stent thrombosis is greatest 2 to 6 months following implantation. Usually, the risk is usually high at the time that the stent is being passed, not within 2 to 6 months following implantation. So option B is the wrong option. Dr. Gordon, please, can you take it up? Yeah.
Please, can you see it now? Hello?